For this session, we are going to talk about skeletal radiology. I will be dealing with the normal appearances of the bones as well as the pathological findings such as fractures of the bones. I'll start from the skull down to the foot. So let's start first with the skull and the face. When you request for a skull x-ray, there are three standard projections. They are the PA view, lateral view, and Townes view. These views are important to demonstrate a particular structure that you will see in the skull x-ray. This is the PA view, and you are able to see the frontal bone, the frontal sinuses, and take note that the orbits are obscured by the petrous pyramids. This is the lateral view of the skull. We usually would take a right and the left lateral view. And this is the so-called Townes view, wherein we would like to study the occipital bone. The adult calvarium is composed of three layers: the inner and outer layer of compact bone and the diplo. The diplo is a less dense area of cancellous bone, and it is the spongy structure of the diplo that produces the granular appearance of the skull. On the lateral view of the skull, you would see the sutures, the coronal and lambdoid sutures. They will have a serrated appearance. As you can see here, this is the lateral view, and here you would be able to see this serrated structure, which represents the coronal suture, and posteriorly that would be the lambdoid suture. Acute trauma to the skull. So we have to look for fractures. And on the skull x-rays, the linear fractures are easier to identify on plain films rather than by CT. And so what are the x-ray findings of fractures? Fracture lines are more lucent than vascular markings. Fractures are usually straight or jagged. Fractures cross sutures. And if you see fluid level in the sphenoid sinus or opacification of the mastoid, be careful to look for skull base fracture. Here is an example of the radiolucent fracture seen on the lateral view of the skull. The arrow points to a dense structure. This is actually a depressed fracture. So, impacted fractures will produce a radiodensity rather than a lucency. Again, here we see the depressed fractures of the skull. Another one here. Okay, this is a child, and you see here the depressed fracture. On CT scan, bone window will show you an example of a depressed fracture. If the fragments are displaced by more than 0.5 centimeters, the underlying dura has probably been torn. Okay, CT scan will show you beautifully the different fractured areas now involving the face. Here we see the soft tissue hematomas and soft tissue changes, as well as the fractures on the maxillary bones. Okay, here we reconstructed the images. It looks like the skull when you study the anatomy, and here we have a fracture along the medial aspect of the orbits and along the inferior orbital wall. We should not mistake vascular markings for fractures. Vascular markings are also radiolucent. And one of the common vascular markings in the skull that we can see is the one produced by the middle meningeal artery. The groove for the anterior division of the middle meningeal artery parallels the coronal suture. The posterior branch of the middle meningeal artery crosses the squamosal portion of the temporal bone. Here is the anterior groove for the middle meningeal artery. This one is the groove for the posterior branch of the middle meningeal artery. If you want to look at fractures of the face, then you have to add the Waters view, which is a PA projection of the face. And here is how it looks like. You see the frontal sinuses, you see the orbits, you see the maxillary sinuses and its wall, as well as the zygomatic bone. Here is a lateral view of the nasal bone. Now, let's go to the upper extremities. Parts of a long bone would include the epiphysis, which is the cartilaginous end of a bone, the physis, which is the cartilaginous zone between the epiphysis and the calcified cartilage. It's also known as the growth plate. Metaphysis, the flared end of the shaft of a long bone. Diaphysis, the tubular shaft of a long bone. And apophysis, the accessory ossification center. And it serves as attachments for ligaments and muscles. Here is a diagrammatic representation of the parts of the long bone. We see the epiphysis, the physis, the metaphysis, and the shaft, which is the diaphysis. Here is an X-ray of a child, and you still see the growth plate, which is radiolucent. Another example of an X-ray of a child wherein we still see these radiolucent growth plates. How about the shoulder? Radiographically, the shoulder includes the distal end of the clavicle, the scapula, and the proximal end of the humerus. Here, we see here the clavicle, the acromion, the coracoid process, the head of the humerus, and the glenoid fossa. Here is an actual example of the X-ray of the shoulders, which can be taken in the internal and external rotation. Another bone that can be examined would be your clavicle. Here is an example of fracture of the clavicle. The glenohumeral joint is the major articulation of the shoulder. It is a ball and socket type of joint. The articular surfaces of the humeral head and glenoid are both covered with hyaline cartilage. Okay? Again, views for the uh, shoulder, including the proximal aspect of the humerus. And look at the relationship between the glenoid fossa and the head of the humerus. You see this crescentic structure that should be maintained. Let's talk about the humerus. What are the parts of the humerus? You have the medial epicondyle, where the flexors of the forearm are attached. The lateral epicondyle, the extensor muscles of the forearm are attached. The capitulum, which articulate with the head of the radius, and the trochlea, which articulates with the ulna. You may be wondering why I am describing the anatomy of the different bones. Because when you read in our report, you will know when we say there's fracture involving the capitulum or the trochlea, at least you will know where to look for it. Here is the actual radiograph of the humerus. This is the distal humerus, wherein you would see the trochlea and the capitulum. And this is the lateral view of the joint, the elbow joint. Radius and ulna. Here again, you see the ulna and you see the radius. A lateral view is taken. Bones for the wrist. I'm sure you know the different names of the bones of the wrist. Okay, the carpal bones. The more proximal bones would include the scaphoid or the navicular, the lunate, the triquetrum, the pisiform. The distal bones will be composed of the trapezium or the greater multangular, trapezoid or the lesser multangular, capitate, and hamate. Here is a diagrammatic representation of the different bones of the wrist. Okay? The arrow here indicates the styloid process of the ulna. Bones of the hands. Okay? So here is an actual radiographic examination for the bones of the hands and including the wrist. The pelvis. AP view is the routine radiographic examination of the pelvis. This projection include the iliac crest, each hip joint, and the proximal portion of each femur. A lateral projection of the pelvis provides little useful information because of the superimposition of very dense skeletal parts. Here is an example of an X-ray of the pelvic bone. A Shenton's line is a smooth, curved imaginary line formed by the inner margin of the femoral neck and the inner surface of the obturator foramen. Lateral displacement of the femur disrupts the smooth curve. So here is an example of the Shenton's line. It should be smooth, and on the other side, you see there's disruption, okay, of this yellow line which represents the Shenton's line. The lower extremities. For the lower extremities, we have the so-called Salter-Harris fractures. This will describe 5 types of growth plate fracture. Type 1 is pure epiphyseal separation. Type 2, fragment from the metaphysis accompanies the displaced epiphysis. Type 3, fracture runs vertically through the epiphysis and growth plate. Type 4, it extends through the epiphysis, growth plate, and metaphysis. And type 5 is a crushing type of injury. So type 2 is the most common injury wherein the fracture passes through the growth plate and also includes a piece of the metaphyseal bone. And type 4, where it involves both the metaphysis and epiphysis, growth arrest, and joint deformities are distinct hazards. Here is the diagrammatic and radiographic appearances of Salter-Harris type of fracture. For the femur, okay, you have the head of the femur, the neck, the greater trochanter, lesser trochanter, the shaft, the medial epicondyle, the lateral epicondyle. So actually, we are just applying what we learn in anatomy during our first years to recognize the different portions of the skeleton. So here is a view of the femur. Okay. Let's now go to the knee. In the frontal projection, the patella is obscured by the density of the superimposed intercondylar portion of the femur. The medial and lateral intercondylar spines are well seen within the concavity of the intercondylar notch of the femur. So here is an example of the knee joint, and you see that the patella superimposes on the femur. So this view is not good to interpret for patellar fractures. And here we can see the intertrochanteric eminence, the lateral condyle, and the medial condyles of the distal femur. Lateral view, we can see the patella clearly, okay? And we can see the patellofemoral joint space. If injury to the patella is suspected, an axial or the tangential or sunrise view of the patella can be requested. And how does it look? Here, we see here the patella very clearly. Again, in the lateral view of the knee, the patella or the patellofemoral space is clearly evident. Pabella. Have you heard of pavella? It is a sesamoid bone located in the lateral head of the gastrocnemius muscle. It should not be mistaken for a fracture. And here, posteriorly, if you have patella in front, you have the fibula posteriorly. Let's go to the tibia and fibula. Here, we see the tibia, we see the fibula. Is this a young or an old patient? Of course, you know that this is a young patient because of the presence of the growth plate or the physis, which is radiolucent. Let's now go to the ankle. If you request for the ankle joint, we have the so-called ankle mortise view, which includes the malleoli, the horizontal plate of the distal articulating surface of the tibia or plafond, and the ligamentous structures that are not visible on plain radiographs. So, if you're thinking of ligamental tear or probably a muscle injury, then you do not request for a plain radiograph. You know that the MRI will be a better study. Here is the ankle joint, and you see here the ankle joint spaces or the ankle joint spaces, and you see here the malleoli, the lateral and the medial malleoli. Boller's angle. What is Boller's angle? It is formed by the intersections of lines drawn tangentially to the anterior and posterior elements of the superior surface of the calcaneus. The normal range is between 28 to 40 degrees. An angle less than 28 degrees is abnormal. The loss of the Boller's angle may mean a compression fracture of the os calcis. So here, how the Boller's angle is drawn. The foot. The bones of the foot. Here, it's a diagrammatic representation wherein we see the phalanges, the metatarsals, the tarsal bones. Here is the lateral view. As you can see here, the calcaneus, the talus bones are clearly delineated. Example of the x-rays of the foot. Okay, let's talk about now the spines. We'll start off with the cervical spines. C1 fracture or the Jefferson fracture, it's a bilateral offset of the lateral masses of C1 relative to C2 on the frontal projection. And C2 fracture is so-called hangman's fracture. It's a bilateral fracture of the neural arch anterior to the inferior facets. Here, we see a CT scan of the cervical spine, and we can clearly delineate the anatomy. What is Colles fracture? Colles fracture involves the distal 2 or 3 centimeters of the radius with dorsal angulation of the distal fragment. You know that this is the so-called silver fork deformity. And this is important, no? Because you don't only have to examine the distal radius, but you have to look at closely the ulna, because Colles fracture is frequently associated with an avulsion fracture of the styloid process of the ulna. Here, X-ray of Colles fracture. We see here the ulna, the radius. Included would be the carpal bones. So when we look at the radiographs, even if your request is only for, say, the carpal bones, if we see fractures like in the radius or the ulna or the carpal bones, we have to include that in our report. We also would like to use two views. One in the frontal projection and a lateral view. Sometimes we will not be able to identify fractures in the frontal projection, but we may see it either in the lateral or oblique views. Shoulder dislocation. The anterior dislocation is the most common. And in shoulder dislocation, the humeral head is displaced forward, anterior to the glenoid, and comes to rest beneath the coracoid process of the scapula. It is also known as a subcoracoid dislocation. Here, this is the glenoid fossa, and you see the displacement of the humeral head. Here, aside from having dislocation, you also have fracture of the proximal humerus. For carpal bones, the most common fracture involves the scaphoid or navicular bone. Here is an example of the navicular bone fracture. Let's now go to the femur. The usual sites that can be fractured would be the subcapital, transcervical, basicervical, intertrochanteric, and subtrochanteric regions. I'm showing you here the example of a subcapital fracture. Here is the radiographic equivalent. We see the transcervical neck fracture. We see the intertrochanteric fracture and the subtrochanteric fracture. Here, close-up view of fractures of the proximal femur. Fracture healing. If we know how to look at the fractures, whether they are linear fractures, usually presenting as a radiolucent focus, or if we have an impacted fracture, it will appear as a radiodense structure. We also have to know fracture healing. And the most reliable Röntgen evidence of beginning bone union will be the presence of periosteal callus. It is seen as a faint, hazy area of calcium densities in the tissues overlying the fracture lines. Okay, here is an example of a fracture, a radiolucent focus, and here is an example of callus formation. So, callus is a dense focus on X-rays. So, I think I tried to give you the more basic anatomy and some of the fractures that you will encounter with regards to the skeleton. And for any questions, you can message me through Blackboard. Thank you.